arrhythmia, atrial fib. So when you talk about atrial fib, so from afar, you don't know atrial fib, you don't know the condition. So from afar, when I say atrial fib, what comes into your mind? Based upon what you have learned, atrial fib, what comes into your mind? From afar, what comes into your mind when I'm talking about atrial fib? Are you there, class?
Yes, please.
Please hurry up. I want to finish the traffic today. Hurry up.
You would think there is a fast chaotic rhythm coming from multiple foci, and the origin is the atrial myocyte.
So it's a fast, chaotic rhythm. Fast, chaotic rhythm coming from where? Oh, coming from where?
Multiple foci, and the origin is the atrial myocyte.
Don't go back to. It's a fast, chaotic rhythm coming from multiple foci. In where? In the atria. In the atria. So when you talk about atrial fib, that atrial fib, that's fibrillation. Fibrillation is fast, chaotic rhythm. And this fast chaotic rhythm is coming from multiple foci. And as you said, the source is atria. So this is telling us this fibrillation is giving us the pattern, giving us the rate. And the atrial is giving us what? The source. So in every description of any type of arrhythmia, there's a source, there's a pattern, and there's a rate. So when you talk about atrial fibrillation is simply there's a rapid, and I told you the last time. So when a patient comes with this pulse, and the description of the pulse is irregular. I will explain these two words. Irregular. When a patient comes with this type of pulse, then it simply means that the patient is having what? Fibrillation. So it's irregular. So when there's a rapid, irregular atrial rhythm, then you'll be talking about atrial fibrillation. When we are talking about rapidly, irregular atrial rhythm, then you are talking about atrial fibrillation. And I'm saying that if a patient comes with this type of pulse, where it to be irregular, and there's fibrillation. And the fibrillation is coming from the atrium, because you could have fibrillation coming from the ventricle. You have fibrillation coming from the atrium. So fibrillation coming from the ventricles are life-threatening, it's deadly. The fibrillation coming from is common, it is treatable. Okay, so we are saying that this fibrillation we're talking about, so let me say this, and I'll be asking you questions. So there's a multiple wavelength when you are talking about fibrillation. There's a multiple wavelength of chaotic re-entry of impulses into the atrium. And these chaotic multiple wavelengths of impulses for atrial fibrillation, it starts, and it's very important to note this, majority of cases, patients with atrial fibrillation, majority of cases, it starts from the venous structures. There's a firing or abnormal discharge from the venous structures closer to the heart. So when you talk about the venous structure closer to the heart, who can tell me any venous structure closer to the heart?
Superior vena cava.
I'm taking it again. And now rush, think. I'm asking about there's majority of cases, there's these ectopic focus coming from okay, so I am saying that majority of cases, patients will develop atrial fibrillation. Patient will develop atrial fibrillation. Majority of cases, it starts from the venous structures closer. There's an ectopic beat or ectopic beat. And these beats start from the venous structures closer to the heart. So can you tell me any venous structure closer to the heart?
The pulmonary vein.
Pulmonary vein.
The lungs.
Venous structure.
Not the lungs.
It's not the lung.
The pulmonary vein.
It's the pulmonary vein. Good. It's the pulmonary vein. It's not the lung. So this is venous because we have the pulmonary vein that will take oxygenated blood from the lungs to where? To the heart. You get it, class. So we have the lungs here. And we have pulmonary artery. And we have pulmonary vein. So this, if I'm asking about the venous structure closer, adjacent to the heart, adjacent to the heart. So this is pulmonary structure. The venous structure adjacent to that. This is the pulmonary or the venous structure adjacent to the heart. I didn't talk about the artery, pulmonary artery. I talked about venous structure adjacent to. Let me simplify it and say that what is the venous structure adjacent to the atria? Because we are talking about atrial fibrillation. What is the venous structure adjacent to the atria? And these structures predominantly, or in a lot of cases, would initiate these atrial fibrillation. Other causes are there. We're talking about other causes. But majority of cases, the venous structures closer to the atria. Who said the lungs? Is it Solomon? Is it Solomon? So this
Yes, Doc. Yes, Doc.
why the lungs?
No, that was what I was thinking, was close to the structure, that's why.
So I am saying this. Don't rush to answer questions. I was asking about the venous structure. So it was a direct question. The venous structure closer. So what it will happen is that these structures will be releasing impulses to the atria. These impulses will now be bombarding the AV. So these venous structures will initiate this. Majority of cases, the atrial fibrillation will be initiated by the venous structure closer. And take note, when I say venous structure, this is venous, the vein, pulmonary vein. The venous structure closer to the atrial is the pulmonary vein. Pulmonary vein. And when these impulses are discharged into the atria, and there will be those impulses will now be having a different. There's a release. Assume there's a release from here. There's a release from here. Now we have impulses, different wavelengths, getting into the atria. When they get into the atria, an organ that will suffer is the sinoatrial node. It's like you have a family at home, a family of two, and you go out and bring your friends. So you bring your friends, family of two, then you have about 6 now, because you have your friends joining you. When your friends comes, the problem will be on your parents. They have to increase the amount of money that they will be used to feed. So it's the same thing happening here. Now there's impulses getting into the atria. When these pulses get into the atria now, these impulses will be traveled to the AV node. So there will be a multiple wavelengths. It is chaotic. Why is it chaotic? It's chaotic because it's different wavelengths. Now this will get into here, this will get into here, and these impulses will now travel towards the AV node, and it will stimulate any myocytes in front to stimulate those myocytes. So there will be a multiple wavelength, and this multiple wavelength will make the whole thing chaotic. So we have this, and we have multiple wavelength of impulses getting from the venous structure to the atria. When these impulses get into this, then they'll be traveling to the AV node at different times. So this is about 90%. This is how majority of cases, this is how atrial fail. We have other causes. Heart failure can cause atrial fibrillation. And when I get to that, I'll explain. But majority of cases, atrial fail is caused by, it's initiated and it starts by venous structures closer to the atrium. These would initiate impulses. There will be an ectopic that would initiate this. And there will be a further impulse getting into the atria. When they get into the atria, they change the rhythm. Because now we are getting chaotic, different wavelength of impulses getting into the atria. And these are going to bombard the AV node at different times. So that is that. You should also note something. Patient coming with atrial fail. Because there's different wavelengths of impulses getting into bombarding the AV node. The atrial will appear as if it's not contracting. You should know this. Because if this impulse is causing contraction, this one can set in and also cause. So the rhythm will be chaotic. And if the rhythm is chaotic, it will appear as if the atria is not contracting. Please, do you get what I'm saying? Do you get what I'm saying?
Yes.
So that is one danger in atrial fail. Because there's a chaotic rhythm, fibrillation. When there's a chaotic rhythm, the atria will appear as if the atria is not contracting. Because the contraction will be disorganized, chaotic. So what happens is that is why when you understand these things and you are managing it, and we say that give this drug, you appreciate this. So the danger is that if this appears, the atria will appear as if it's not contracting, because we have thus nullifying each other. So it will appear as if it's not contracting. And the danger is that there could be stasis. This will lead into stasis within the atria. And if there's stasis, then another danger is that the blood will become hypercoagulable. The probability that the blood will clot because we have stasis behind. So patient is at risk of clotting because of the stasis, because of the chaotic nature of the rhythm. So there will be stasis. And this stasis would make the system hypercoagulable. And if the system becomes within the heart becomes hypercoagulable, then the risk of the patient developing clots will be high. And this is the number one danger. So any patient who comes with atrial fibrillation should be on anticoagulants. Because of these mechanisms. Because when clots form, these clots could be thrown into the system, and the patient can develop stroke, patient can develop PE, patient can develop DVT because it's strong into the system. So any patient with atrial fib should be on anticoagulant. So that is that. So the key point is that in atrial fib, the key point is that majority of cases, the atrial fib is initiated and maintained by the venous structures closer to the atria. They would initiate all these and maintain the atrial fib. So there will be different wavelengths of impulses getting into the atria. These impulses getting into the atria would, at the end of the day, be bombarding the AV node, because different wavelengths getting into the AV node at different times. You'll be bombarding the AV node. The next thing that you need to know is that when we have atrial fib, the atria tends to appear as if it's not contracting. This will lead to stasis over there. This stasis will make the system become hypercoagulable. So the risk of clotting becomes high in atrial fibrillation. Therefore, this will call for the use of anticoagulant. Based upon this, who can tell me some of the risk factors? If I tell you to mention about 2 or 3 risk factors for atrial fibrillation, who can tell me any of the risk factors? Any of the risk factors? Any risk factor for atrial fib? Hey, am I muted?
No, sir.
Any risk factor for?
So one of the factors can be hypertension or heart failure, as you said earlier on.
Hypertension is one. Heart failure is also one. Any other? So
Obesity.
Heart disorders. You could also have age. Normally, about 10% of patients or people with age greater than 80 years normally develops this easily because these will develop heart disorders, problems. And because they are developing heart problems, it's easy for them to get these atrial fibrillation. So note this. It will seem some way, but you will note this.
Sir, please, can you come again with the age?
I am saying that age is a risk factor. Atrial fibrillation. I'm saying that about 80% of people above 80 years will easily develop what? Develop about 10%. And you can link this because you are saying heart disorders. Patients with heart disorders are at risk of getting what? Atrial fibrillation. And therefore, at age 80, then you know that these things will set in, heart problems will set in. These people will be at risk of developing atrial failure. So age is a risk factor. Heart disorders will also be a risk factor. And there's this, take note of this risk factor. It will not seem some way, but it's a risk factor. It seems some way, but it's a risk factor. So men and whites are more likely to develop. Men and whites are more likely to develop atrial failure than women and blacks. Men and whites. This statement looks some way, but it's a risk. Men, and when you sit down quietly, you can deduce. Men and whites are more likely to develop atrial failure than women and blacks. So these are risks. So who can tell me why whites? Can you tell me why whites are prone to getting this? If you don't answer me, I'll go on.
Dr. Attakorah, please, it's likely due to the fact that most of their foods are rich in lipids and fats, so it increases their chances of getting heart disorders, which it makes it easy for them to get AFib.
Mm-hmm. You have a point there. You have a point there. Any other? You have a point there. Any other? You have a point there. Any other?
Genetics.
Look at their lifestyle. You talked about the junk food that they are stopping. We are embracing it. The junk food. They eat this junk food because it's cheap. Right there. Hold on for me.
I know, like you can identify. I'm strange. I just don't want to get there. How? Stacy.
Hello.
Hello.
So I'm talking about the junk food. The junk food. We are now embracing the junk food. Our local food, we don't like it. Especially the ladies. When you buy the local food for them, they want the pizza. When you buy the pizza for them, ice creams and coke, and you think that you love them. When you buy a watch it, when you buy your kogari, you are laughing. For them, they will tell you, hey. So the junk food that they are eating, now we are also getting cardiovascular disorders. Cardiovascular disorders are linked to this atrial fibrillation. So in no time, we will also be getting a lot of these conditions. Initially, kidney wasn't common. Liver condition wasn't common. But now it's too common. Liver is common because of our lifestyle. Atrial fibrillation is not common. It's too common in our side. It's so common. Because of our lifestyle, it will also be common. It will be common. I learned that, especially the student, the way you are abusing things and you think it's the order of the day, you are abusing the marijuana, the weed, and the cocaine. The way you are abusing these things, you are making toffees out of this. You are cooking these things. So if you don't take care and you visit your friend, you think that he has given you coke, has given you this, and you'll be eating different things.
Doc,
Fine. Hello?
Doc,
I'm listening.
please, I hear that it is the smoke that's harmful, but the drug itself is not.
Whatever. You take it as that. It's the smoke. It's not a drug. At the end of the day, it's one thing. At the end of the day, it's one thing. Why you become addicted? At the end of the day, what is the benefit? Suicidal tendencies are occurring. You tell me these are the nice things that you be saying about the whole thing. You be pushing people into that. People are you came from a different area, places. You go after school to your place alone. So don't copy these bad things and tell me it's the smoke. At the end of the day, they are one. You change your system. And outside, they're having a lot of psychiatry issues. So if you go to outside, psychiatry medications are common. Depression and those things are common. Why? Because of these things. And the nicest way is to say that, oh, this is okay. This is this. Oh, it will do this. It's better to avoid these things at this tender age and to be brutalizing the whole thing. Tell me that it's the smoke. So if it's the smoke, why is it that people will be addicted? When you become addicted, without that, that's a problem. So our lifestyle will be giving us these complications. Somebody could also tell you that, oh, I've taken this for ages, I'm not getting it. You are one out of something. When you are talking, you talk about the percentage. Get to confirmation, get to the psychiatry. You see that young ones are there, special students. I was doing a work. I stopped. Initially, I was at psychiatry. I was doing a work, looking at a friend of mine, son, about 24, went to university because of these things, ended up in psychiatry. Now he's gone. So the thing is no good. It's better to avoid than to be talking about A, B, C, D. The mentor, I started doing these things. This was to find out students, the prevalence of these in students. So lifestyle. Time will come, I'm saying that traffic will be common because of a way of life will be common. So let's talk about the causes. What are some of the causes of traffic? We have talked about risk factors. We talked about the fact that hypertension is a risk factor. So cardiovascular disorders can also cause that. Any condition that would affect the heart could easily cause a traffic. So congenital heart defects can cause that. You could have holiday heart. Holiday heart. What is holiday heart? What is holiday?
Dr. Attakorah, please, the holiday heart syndrome is when you can't have enough alcohol. It's like you've taken a lot of. Wait, since I'm coming.
You should come on. So congenital heart defects, there could be ischemic cardiomyopathy. It also affect it. Hyperthyroidism could also cause a mitral. Valvular disorders could also cause that. So these are some of the causes. Hyperthyroidism, hypertension could cause cardiac defects, and these can tip the patient to having atrial fibrillation. Understand atrial fibrillation, where there's chaotic. This is what you should know. There's a chaotic rhythm, fast chaotic rhythm coming from a different foci within. So that is the fibrillation. So we have this different foci discharging what? Discharging impulses. So there will be a chaotic rhythm. 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 And because it's fast, and these impulses are coming from different foci or multiple foci, it becomes fibrillation. So the danger of fibrillation is when there's abnormal bombardment of these different wavelengths on the AV node. Another thing is that the atria seems not to contract. So if the atria is not contracting, if the atria seems not to contract, what will be the nature of P wave? What will be the nature of P wave?
flat.
So the groove will appear as flat. Huh? These are some of the interpretation. So this is not contracting. So you not be getting something like this as the P wave. It will be flat. So that is that. So the atrial fibrillation, what in majority of cases, what would initiate the atrial fib will be what? Venous structures closer to the atria. The venous structure closer to the atria is what? It's the pulmonary vein. Pulmonary vein. That is closer. So note that. And I say that if the atria appear not to contract, there will be stasis in there. And when we have blood stasis in there, what will happen is that area becomes hypercoagulable, so clots could form easily here. So these clots could even be here and be thrown. So the danger is that you could be getting systemic emboli. These systemic emboli could affect different organs, could affect the brain, affect the lungs, could go into the deep vein thrombosis. We're getting occlusions. Could have caused, it could occlude the arteries that supply oxygenated blood to the kidney. So acute kidney injury could develop. I wish you understand. Please, you understand up to this point. As I'm moving to the classification, you understand up to this point.
Yes, sir.
Okay, so let's learn about classification of atrial fib. Classification of atrial fib. So we can classify atrial fib into about 3 or 4 or 5 types of atrial fib. One of my professional questions about a year ago, last year or so, about the lone atrial fib. When I say lone atrial fib, what does it mean? Lone atrial fib. So we have types of atrial fibrillation. So when you say lone atrial fib, it's atrial fib without any identification or any identifiable cause. You cannot any identifiable cause. So atrial fib is an atrial fib without any identifiable cause, especially in patients less than 60 years. Patient above 60 years, we can say that it is ABCD. But patient less than 60 years, coming with atrial fib without any identifiable, you cannot say this is causing it. This is causing it. So when you have such a thing, we say it's a lone atrial fib. So a lone atrial fib is atrial fib without any identifiable cause in patient less than 60 years. Less than 60 years. Another type is acute. Acute atrial fib. Acute atrial fib. So acute atrial fib is also a new onset of atrial fib. A new onset of atrial fib lasting less than 48 hours. Acute is a new onset of atrial fib lasting less than 48 hours. So if we have The patient comes the first time of getting atrial fib. And these acute atrial fib, there will be resolution less than 48 hours, less than 2 days. The patient comes back to sinus rhythm, normal sinus rhythm. Such atrial fib is termed as acute atrial fib. It's a new onset of atrial fib lasting 48 hours. So the third one is paroxysmal. Paroxysmal atrial fib. Paroxysmal atrial fib. Paroxysmal atrial fib. So when you have recurrent atrial fib, that typically lasts. Recurrent atrial fib. Long atrial fib is that you don't know what is causing it to certain age group, less than 60. Acute is a new onset of atrial lasting less than 48 hours. When you talk about paroxysmal, it's recurrent atrial fib that typically lasts less than 48 hours. Paroxysmal, listen to paroxysmal word. Is a recurrent atrial fib that typically lasts less than 48 hours. And spontaneously, these fibrillations spontaneously convert to normal sinus rhythm without any medication, spontaneously. So paroxysmal, the key words is that there's a recurrent atrial fib, recurrent, that typically lasts for less than 48 hours and converts spontaneously to normal sinus rhythm. Converts spontaneously. Acute is a new onset, a new episode of atrial fib lasting less than 48 hours. That is acute, a new onset. Long atrial fib, we don't have any identity. Patient is having atrial fib. We don't know what is causing the atrial. So paroxysmal atrial fib is a recurrent atrial fib that lasts less than 48 hours and converts spontaneously to normal sinus rhythm. We have another type called persistent. So persistent atrial fib. Persistent atrial fib. When we talk about persistent atrial fib lasts more than 1 week. It lasts more than 1 week. And for persistent atrial fib, you need to treat it to convert it to normal sinus rhythm. So when you talk about paroxysmal, is recurrent, lasting less than 48 hours, and there's spontaneous conversion to what? The normal sinus rhythm. Persistent atrial fib lasts more than 1 week, and it requires treatment to convert it to what? To normal sinus rhythm. We have the last to be the permanent. The permanent is that you cannot convert this. You cannot convert this. When the patient comes with permanent atrial, you cannot convert it using what? To sinus rhythm, using treatment. So you cannot treat it when the patient comes with what? Permanent. And there's something that you need to know. If you take stroke, or let me use this, epilepsy, the more the patient is having that seizures, the more you are causing damage to the brain. So the more the patient is having these fibrillation, the more the patient is developing remodeling. And this remodeling will cause cardiac defect. And therefore the patient will be prone to or have that risk of getting these atrial fib. So we shouldn't allow atrial fib to persist. So when you have any clinical manifestation of this quickly, you need to see the cardiologist for that. So these are some of the classifications. We have persistent atrial fib, we have permanent atrial fib, we have acute atrial fib. So before I move on to signs and symptoms, let me ask you this. What is persistent atrial fib? What is persistent atrial fib? I'm asking a question to the class. What is persistent atrial fib?
Hello.
Please.
This is when the atrial fibrillation lasts more than 1 week. And you mentioned that it requires treatment to be able to convert it to the normal sinus rhythm.
Okay, good. Abigail, good. Good. So that is who can tell me about paroxysmal atrial fibrillation?
The paroxysmal AFib is a recurrent AFib that typically lasts less than 48 hours, and it should be and spontaneously converted to normal sinus rhythm without any medication.
Okay. Okay. So that is that. So let's, based upon what is happening, there's a chaotic rhythm. If there's a chaotic rhythm, the AV node will be bombarded. Bombardment of AV node by different wavelengths of these impulses. What will be the effect of the cardiac output? Who can tell me? What will be the outcome of the cardiac output? So if this is AV node, AV node is being bombarded by these. So who can tell me the cardiac output? What will be the cardiac output? Cardiac output.
It will be low.
Why low? Why would the cardiac output be low?
There wouldn't maximum relaxation and contraction.
So I want you to use a word. We are talking about chaotic. So what would be the rhythm? What would be the ventricular rhythm? What would be the ventricular rhythm? Kingsley, the cardiac output will be low. Why? Kingsley, your hand is up. What will be? Why is it that the cardiac output will be low? And therefore, if a patient comes with atrial fibrillation, patient with atrial fibrillation will easily get heart failure. Will easily get heart failure. Atrial fibrillation patient will easily get heart failure. And heart failure patient can also get atrial fibrillation. Let me explain this to you. Let me explain heart failure and atrial failure. If the fibrillation, listen, if the fibrillation is not caused by the venous structures closer to the atria, that is the pulmonary vein, if it's not causing that, heart failure can also develop atrial failure. And this is what could happen. Now you have atrial node. You have atrial node. When the heart is failing, what will happen is that the sinoatrial node will try to release impulses. But if it's still releasing impulses, and these impulses is not, because the impulses would cause the contraction. Sinoatrial node is releasing impulses. The contraction is not, it's still going down. What will happen is that other areas will try to support. It's just a compensatory mechanism. We try to support. My size A can decide that, oh, let me also, because the heart is failing. So other sites, because the heart is so specialized, other site could also decide that let me also give debrief. So impulse generation from these sites will also come at different wavelengths and come and also bombard this. So atrial fibrillation, if a patient develops atrial fibrillation, there will be irregular rhythm of the atria, and there will be irregular rhythm of the ventricle. There will be irregular rhythm of the ventricle. And because of the irregular rhythm of the ventricle, what will happen is that the output will be low. And if the output is low, then you'll be developing what? Heart failure. The patient is having heart failure. How would the patient develop arrhythmia? Especially atrial fibrillation is common. Heart failure patient can easily get atrial fibrillation. It's the commonest thing. Heart failure, develop atrial fibrillation. And I'm saying that if we need the impulses from the sinoatrial to stimulate the heart to cause depolarization. So if the impulses being released from the sinoatrial node are not enough, and the contraction still going down, it means that the heart needs support. So the other areas will try to support by also releasing what? Impulses. It's the same as when you see, so you are with a class, with your friends, and you see that one of them, if you say one of them is going down, is fainting, a class, you individually, you try to do something. And trying to do something just to hold the person or just to help the person. This is the same behavior. The myocytes also try, atrial myocytes also try to do something, just to push more impulses to cause the contraction. By so doing, it could result to fibrillation. So I keep on telling you this. When I was doing heart failure with you, I said this. Normally, the compensatory mechanism, when you prolong it, would worsen the condition. So now there's heart failure. There's a compensatory mechanism here. And this compensatory mechanism will be worsening the heart failure. Why? Because there will be fibrillation. And this fibrillation would further reduce the ventricular output or the cardiac output. That will be done by the ventricles. So in managing atrial fibrillation, the first thing that you need to think about is how to regulate the ventricular rhythm. Very important. I've told you when there's a problem in the atria and the ventricles are working well. I told you the last time that you could have issues with the atria, but when the ventricles are, the rhythm is okay, it's pushing, you will not see it much. But the ventricles, when you have small issue about the ventricles, it could be seen easily. So the first thing in mind is to make sure that this area, the rhythm in this area is okay. That is the first thing. If it's okay, this area can push blood to the brain, push blood to the other vital organs, such that there won't be any problem. So when you're managing a traffic, the first thing is to think about this area. We'll be talking about this. Okay, so based upon this, what could be the signs and symptoms? Signs and symptoms of atrial fibrillation. Normally, atrial fibrillation is symptomatic. Normally, it will be symptomatic, but patient can also develop this. When it's getting severe, patient can also develop this. For me, some of the clinical manifestation of atrial fibrillation.
So we have difficulty breathing.
So there could be difficulty in breathing.
Chest pain.
Come again.
Chest pain.
There could be chest pain, but we say there's a vague chest discomfort. Vague. There's a vague chest discomfort. Which pain could be one of them? What again?
Palpitation and fatigue.
There could be palpitation, there could be fatigue. And you should know why there's palpitation and fatigue. Please, you should know. What again? What again?
So I'm looking at tachycardia.
Dizziness.
There could be dizziness on those. And note this. There could be symptoms of heart failure. Symptoms of heart failure will be there in atrial fibrillation. Symptoms of heart. So when you know the symptoms of heart failure, because atrial failure will reduce the cardiac output. If cardiac output is reduced, then what do you have? You have the heart failure. So symptoms of heart failure. So you should know the symptoms of heart failure. That's why somebody said difficulty in breathing. Said it. Any other? What will be some of the complications of atrial failure? Who can tell me some of the complications of atrial fibrillation?
There could be pulmonary embolism. There could be pulmonary edema.
There could be pulmonary embolism. Pulmonary edema. If I ask you the pulmonary edema, is you able to tell me? Huh? Don't just be saying these things. Orals, when you sit, you see me. These small things. I don't normally push students. I don't normally do that. Because that is your last week. So I don't normally be asking questions. What I like doing is that I like you to prove to me. I'll be asking you areas that you learned when you were in school, when you were at the hospital. And when I ask you this, I want you to tell me the things that you know first. Don't tell me pulmonary edema. When I ask you why pulmonary edema, you'll be there. Some of the care issues. So you should have some care issues. In case they ask you what you learn, what those things, you just, hey, cook something and put it at the back of your mind. But do you know what? You people, you cook it. You get to the place. The things that will cook become uncooked. They all vanished. You should have something. What you learn. Okay. What are some of the complications? What are some of the complications?
There could be stroke, and there could be DVT.
Stroke, DVT. What again?
You can also have cold extremities.
It could be cold extremities because of the poor perfusion. Because of the poor perfusion. Okay. Let's move to the diagnosis. How do you diagnose atrial failure? How do you diagnose atrial failure? How do you diagnose atrial failure? So, basically, arrhythmias are diagnosed using ECG. We use the ECG to diagnose atrial failure. And when you use the ECG to diagnose the atrial failure, there are certain waves that you have to. The waves behavior, some of these waves, you should expect certain wave and certain behavior of some of the wave, the P wave. So the ECG. So for the ECG, in atrial fibrillation diagnosis, you should look at the P wave. You should look at the P wave. And the P wave, there should be absence of what? Absence of what? P wave. That is a key thing. In atrial field, there should be absence of P wave. We have another wave called, I told you we have a lot of waves. We have A waves. We have Q waves. We have F waves. So All these things will come in different conditions. In atrial fibrillation, we have F waves. And these F waves, we call it fibrillatory waves. Fibrillatory waves. This is a wave. And you should see these fibrillatory waves. And these waves are always come in between the KRS complexes. So it comes in between. So we have KRS complex. Before we get another KRS complex, you'll be having these fibrillating waves. So this will be the F wave. This will be KRS complex. So this will be the fibrillating waves. So that is that. Another thing that you should expect is that for fibrillation, we use the word irregular. The pulse is irregular. That is the pulse. The pulse is irregular. What does it mean? Who can tell me the meaning of this? Irregular. Talking about the pulse. So,
Hello, Doc.
I
I'm looking at the irregular as a result of because of the various impulses. The various waves will come at the AV notes at different times. So this will result in the irregular waves at the AV note.
So, if I say morphology, do you understand morphology? If I say morphology, do you understand it? Yes or no?
No, Doc.
I'm asking the class. Talk about the morphology of the heart. What is this? Am I muted?
No, Doc.
I'm asking about morphology. If I say morphology, what does it mean? Hmm? Hey.
The
Morphology.
structure of the heart.
What?
The structure and then the form of the heart.
So, morphology, talking about the shape, talking about the size, morphology. So, we're dealing with morphology. So, we call it listing. We use the word irregular. Why? So, we are using two things to say, to link it to irregular. The timing, the rhythm, the timing is irregular. And because the timing is irregular, the morphology will also be irregular. So we use these two ways to say that in atrial fibrillation, the morphology and the timing, they are all irregular. And therefore we say that it's irregularly in timing, irregularly in morphology. The last one is that when you take this, when you take the ECG, the pattern, you could have R interval, R interval. So let me clean this. So R interval. So we have this Q R what? X. We have another this. So R here, R here. This R interval here. Who can say this R interval will be what? Who can tell me what the R interval will be? This R interval will also be irregular. Will be irregularly irregular. Why? Because of the chaotic nature, chaotic rhythm. The R interval will be also be irregularly irregular. So they'll be using these things to interpret for the diagnosis. The major is the ECG. The major two is the ECG. The next thing that you can do is that you can also do echo. Echo can also be done for the patient. And for the echo, we use the echo to assess the structure of the heart defect. We want to assess whether there's a structural defect of the heart. So we want to check whether there's left atrial enlargement. We want to check whether there's any abnormalities in the left ventricular wall, any abnormality. We want to check whether there's any ischemia at past or present. So we use the echo to also to assess the structure of the heart defect. That is that. We can also check the thyroid function test. Thyroid function test can also be done. These are other tests that can also be done because hyperthyroidism could cause atrial failure, because hyperthyroidism can cause hypertension. And at the end of the day, hypertension can damage it. Hyperthyroidism can cause heart failure. At the end of the day, heart failure can result to this atrial fibrillation. So these are all. So we do the ECG, and the ECG, you look for the F waves, fibrillatory wave, F waves. You should expect the absence of the P waves. You should expect this. And you should check the RR wave, because arrhythmia is irregularly irregular. And irregularly irregular means that the timing is irregular. The morphology also is what? Irregular. The last thing I'll be talking about this is the treatment. How do you manage fibrillation? I'll not be talking about they have what you call a radio frequency ablation. They have that. I'll not be talking about these instruments. I'll be talking about only the medications. We have other instruments that can use to cause this cardioversion. They have this, the cardioversion. Converts these fibrillation to what? To the sinus rhythm. We do that. Okay, so for treatment, when you want to treat atrial fib, looking at 3 areas. You look at the ventricular, first thing that you should look at, because you should thinking about the other organs. These organs should be getting what? These organs should be getting enough perfusion from the heart. So you should think about the ventricular rate control. That's the first thing that you should think about. Ventricular rate control. Or certain books will say rate control. That is ventricular rate control. The next thing after correcting the ventricles, you think about the rhythm control. Now think about having the rhythm control. So first, make sure that you correct the ventricular rate control. The second is to think about the rhythm control. Then the third one is that in doing this, you have to put your patient on medication that will prevent what? Thromboembolism. Put your patient on medication that will control thromboembolism or clots. Okay, so let's now do the rate control. Let's now do the rate control. And I want you to think, I want you to think, how are you going to manage the rate control, ventricular rate control? How are you going to manage it?
You can use beta.
Why beta blockers? I want you to think, why beta blockers?
Dr. Attakorah, beta blockers can shut the AV node down and prevent it from transmitting impulses.
Why are you shutting? If you shut it, then you'll be getting a 3rd-degree block. You get it?
You would want to reduce the impulse rather, not to shut it down.
So you shouldn't think about shutting it down. There's a bombardment. This is the heart. We are having fibrillation. So I was stressing on this. When you have fibrillation, there will be bombardment of impulses. When you have atrial fibrillation, bombardment of this. And this would affect the rhythm, the ventricular rhythm here. This will affect the ventricular rhythm. So the first thing, if you want to control the ventricular rhythm, it means you have to control amount of impulses that will go through where? That will go through the AV node. And in doing this, because this is slow channel tissue, I'm coming back to what we learned. Because here's an atrial node is a slow channel tissue, then you need to consider medications that would affect the slow channel tissue. So we do a beta blocker. We do a beta blocker. Special beta blocker it's the use of beta blocker is good, especially when we have excess catecholamines. When you suspect excess catecholamines resulting in easy traffic, then beta blocker will be the best. But in all this, beta blocker will be used to control the ventricular rhythm, to control amount of impulses that will be leaving the AV node to the ventricles. Because we have so much impulses bombarding the AV node here. So you need a drug that will control this, reduce these impulses getting into that. If a patient, assuming you have asthmatic patient, how are you going to control the ventricular rhythm? Asthmatic patient coming with a drug. We're doing what?
If you can use calcium channel blockers.
You can use calcium channel blockers. What type of calcium channel blockers?
The non-dihydropyridine.
Example.
Diltiazem.
So I am asking example. I'm asking this. The next will be the dose. The next will be side effect of contraindication. Those things. So make sure you know details of verapamil. It's not used too much. But it's non-dihydropyridine calcium channel blockers. So good. You consider those things. Why? Because these also act on the slow channel tissue. So if there's a problem in the slow channel tissue, you think about giving these medications. So you can also consider that. Good. Digoxin. Listen, digoxin is least effective in this. But when a patient comes with atrial fibrillation with heart failure with atrial fibrillation. When there's fibrillation alone without heart failure, then digoxin is least effective. But when it comes with atrial fib with heart failure, then digoxin is one of the best medications to treat those comorbidities. So that is ventricular. So make sure you control. You do the rate control. The rate control is to control the ventricles. Make sure you control the ventricle before you do the rhythm control. Think about the total rhythm of the heart. Then you think about that. The total rhythm of the heart. So for this, the next will be the rhythm control.
Hello, Doc.
Hello.
Doc, I beg of you, when did you say we can use the digoxin? I didn't get it, man.
Who got what I said?
Heart failure plus AFib. That is when you consider digoxin.
So heart failure plus atrial fib. The digoxin will increase the force of contraction in heart failure, and the atrial fib. The digoxin would also reduce impulses getting into the AV node. So that is digoxin.
Thank you very much.
Okay, so the rhythm control, you want to improve the cardiac output. When I'm talking about the ventricular control should be the first thing that you should do. Think about it. Because when you're able to do that, then you're going to perfuse the other vital organ. And the next thing that you should do is that after doing that, when the ventricular rate control is not done, don't go and do the next thing by adding the rhythm control medication. Don't do that. Make sure there's a ventricular rate control. Then when it's done, then you move on to the rhythm control. So the rhythm control is that you want to improve cardiac output the whole. Now the rhythm will be synchronized. The rhythm will be synchronized. And you won't be getting chaotic again. Now you want to tackle the atria. Tackle the atria. Now atria, there's fibrillation in the atria. And you think about medications that should be used to tackle the atria, fibrillation in the atria. So for rhythm control, which medication will you think? Arrhythmia? I don't know. When you understand these things and it gets to medication, then it's just application. You are confused about certain things, but when you understand it, when you are asked about medication, because you know it's something happening here, and because of that, we can do this, we can do this, you can use this medication. For rhythm control now, the ventricle is okay now. So there's a fibrillation. Still there's fibrillation, atrial fibrillation. But we have been able to reduce using the beta blockers, using a non-dihydrotyridines, calcium channel blockers. We have been able to reduce the amount of impulses that will be getting into the ventricles. Now you could regulate the ventricle. How do you now help stop the fibrillation, atrial fibrillation? Which medication will you be thinking?
Amiodarone.
You can think of amiodarone. Why amiodarone?
Doc, please, we know that the class 3, amiodarone belongs to class 3 antiarrhythmics. And we mentioned that the class 3 antiarrhythmics are preferred because they affect both the slow and then the fast channels. And amiodarone is the best one because it can also prolong the QT interval. It's the best medication, sorry, because it's, let me come again. He said,
no.
You said amiodarone because amiodarone is the best choice among the antiarrhythmics because it can affect both the slow and the fast channel.
Predominantly, amiodarone or class 3 affects the potassium channels. And the one danger is that it can cause torsade the pointers. It's affecting the ventricles. It could give you different amplitudes of the QRS complex. You can see now, minimally confused. So you can use amiodarone. Why amiodarone? Because now the atrial, amiodarone can affect this side, atrial. Can affect the atrial. The problem is from the atrial, and the atrial is the first. It's under the first channel. The tissues. You can do that. Which medication can also be used?
The class A.
The class A. Don't just tell me the class A. Tell me, be specific.
Please, you can use lidocaine.
Class A. Which class of the A? Sorry, class 1. Class 1. Which class? Then you tell me class 1F, class 1J, class 1. So which class 1 medication can you consider in this?
Dr. Attakorah, please, lidocaine, which falls under class 1B?
Class
1B.
hey, why not here? Hey, Subanden. Somebody said class 1A. The person is right. Class 1A, class 1C. Don't consider class 1B. We said, what did you say about class 1B?
You said they have fast kinetics.
So if it's having fast kinetics, what does it mean?
It means it can block the sodium channels fast, but then it doesn't last long.
It doesn't last too long. So easily, there will not be any effect. ECG will not be showing anything. It will not show that, no, there's changes. When I give the medication, there's changes in the ECG. It's not potent. So we consider class 1A, class 1C medication for the rhythm control. When you know these things, selecting medication for arrhythmia will not be a problem. Please. That is what
Hello,
I was.
Dr. Attakorah.
Hello.
So, if it is not potent, why is it part of the class?
Come again.
I'm saying that if it is not potent, why is it part of the class? You should have just taken it up.
If it's not potent, why is it part of the class?
Or is it used for a different condition?
The medication over there could be used in other conditions. We also say that, look, we have Sotalol under class 3. It's beta blocker. Sotalol is still under class 3. It's also in class 2. But listen. We could have, if you have a class of medication, let me say sulfonylurea. You could have these different classes of medication. I am telling you, this drug is not potent. Based upon its kinetic, I'm telling you it's not potent. But let me say this. It could be potent for somebody. When you check the classes, you have your students, your mates. Some of them are good in this, some of them are good in this. You can say that this guy is weak or this guy is not good, academically is not good. But this is what we do, blacks. We will tell you are not good. And if you don't take care, you make you useless. But the whites will see something good in that person. You could have these medication, and on paper we say, last time I gave a medication, the patient was complaining of pain. I suggested a powerful medication to painkiller too. He told me that when he takes that painkiller, it doesn't work. But when he takes PMO, it works. And I say, wow, that's good. Then thank God. On paper, we are saying it's not effective, but it will be effective to a point. I'm looking at class A. I'm comparing it to class A. I'm comparing to class 1A. I'm comparing to class 1C. So I'm saying B because if you take the football, the football team, you say this team is no good. Why? Because you are comparing the team to the best. But that same team, let the team who will be last in the Premier League, the London, let the same team comes here to Ghana. You'll be the first. So you are comparing it to, it doesn't mean that there's nothing in there. And at times, due to comorbidities, you will still resort to that monitor. So we tell them this is not effective. It doesn't mean that it's not. In that same class B, you could be using class B in other conditions is effective. But in terms of the arrhythmia, take note of this. Can I ask you a question? If you take bumetanide and Lexis, can you say they are all effective equally? You have equipotent in terms of bumetanide and Lexis. Do you get me? The loop, bumetanide, Lexis, in terms of potency, are they the same?
No, sir.
It's not the same. Which one is more potent?
Ladies.
Bumetanide.
So I mentioned two. You are saying some. One is in Lexis, one is in, what is it? So what do you want me to? So in terms of potency, they are not the same. They are not the same in terms of potency, but they are in the same one class. If I want potency and I have money, I will not do Lexis. I will do bumetanide. And because of money, I resort to. We are not saying it has a zero thing, but I'm comparing the potency to the best because of its cardiac, the kinetic issue, fast kinetics. Because of its fast kinetics, effect is not as the 1A and 1C. So for this, we prefer to go in with the potent, which is the 1A and 1C. Examples of the 1A is what? Just tell me one example of 1A.
Procainamide.
So procainamide. So for if I want to go in with this 1A and 1C, which one will you choose? If at the word they ask you, there's a traffic, you want to use it for rhythm control, which one will you go for?
1A.
Why 1A?
So I'm thinking because the 1A is intermediate between the kinetics, and you get the benefit of it blocking the AFib, and also because it doesn't cause a very prolonged blocking of the sodium channels, you don't experience the side effects as you would with the M1C.
Any other? I will not go in for 1A. I'll go in for 1C. In terms of drug adverse effect, please, you can take 1C or 1A, and you will not experience any side effects. You can just take a dose of 1A, 1C. So when you are giving a drug in a critical situation, at times you weigh the risk. But this is rhythm control. Arrhythmia fast. You need to control the rhythm. So you need a potent medication. I need a slow kinetic one because it's chaotic. Chaotic. If I don't have the 1C, then I can be taking the 1A. I can consider 1A. If I don't have the 1A, then I will resort to what? The 1B. Do you get it? But in terms of the potency, I'll be thinking about first going with 1C. If I don't have the 1C, then I'll be checking in terms of the potency. Looking at this, 1A will be the next. The last one will be 1B. So you look for in your mind, like Lexis and Bumetanide. In terms of potency, it's Bumetanide. But it's because of the price. We're going using what? Lexis. We have been using Lexis and leaving Bumetanide. And the dose, even the dose for Bumetanide is used small doses as compared to the Lexis. So that is that. Please don't. You are thinking about it intermediate. So it has intermediate kinetics in terms of blocking and hooking into that. It's not too fast. It's not too slow. We need a one that will block it and maintain such that these chaotic things will be reduced. The side effect, please, when a patient comes, if it's not contraindicated, then make sure you give the medication. If it's not contraindication and there's something comorbidity that's making you not to give, don't be thinking about it, because every medication has its own side effect. So we don't look at the side effect, either than you won't take P more. Because P more, when you look at the side effect, it's too much. But you take it. So when a condition comes and we are managing, if there's no contraindication, if there's no caution, then you shouldn't be alarmed because it does this, it does this. You can give it and the patient will not be experiencing those side effects. So rhythm control. You want to improve cardiac output. Then you think about giving these classes. Class 1C, any medication under class 1C.
Flecainide.
So flecainide. I just want to test you and see whether you can tell me. Yesterday we mentioned class 1, class 3. Can you mention any of the medication apart from Sutalo? Sutalo is also under class 3. Any other medication under class 3?
Ibutylide.
What?
Ibutylide.
Ibutylide. Good. Any other?
Amiodarone.
Oh, I said apart from amiodarone and Sutalo.
Dronidarone.
What?
Dronidarone.
Njama, edi amabu ba cheme.
Dofetilide. Dofetilide.
Dofetilide. It's a njama, edi amabu ba. We have dofetilide. We have ibutylide. These are all class 3 medications. The last thing that you need to think about is please, when a patient comes to fit traffic, don't look at please meet. Don't look at what is causing the traffic. The moment the patient comes to fit traffic, think about giving a medication, prevention of thromboembolism. Prevention of thromboembolism. Prevention of thromboembolism. So the thromboembolism is not antiplatelet. You think about giving what? Anticoagulant. You think about giving anticoagulant. So you give a warfarin. Give a warfarin for the patient. Normally the INR should be 2 to 3 when the patient is on warfarin. You give warfarin and you monitor for the INR. Let me ask you this. Are these about warfarin? When a patient is on warfarin, how will you advise about the food? About the food. How do you counsel the patient about the food?
So they should take a constant amount of especially for the vegetables and those green leafy vegetables which contain some amount of vitamin K. They should take a constant amount of it. So there shouldn't be fluctuations between the amounts they take.
Good. So if you are taking daily, you take 1 ladle. When you are on the warfarin, don't change it. It should be 1 ladle every time. Don't change it. It should be 1 ladle. If I'm expecting the INR to be between 2 to 3, I gave a dose. Assuming I gave a dose of say 5 milligram of warfarin, I check the INR and it's less than 2. What will I do? How will you advise?
If the INR is less than 2, it will give an indication of maybe public coagulation. And it's supposed on something like coagulation.
Come again.
I think that if the INR is less than 2, then you must suspect something like coagulation happening somewhere. But if the NR is greater than the upper figure, which is 3, then you must suspect something like bleeding or occurring somewhere.
So what would you do? A patient is on 5 milligram, you checked, it's less than 2. What would you do?
Yeah.
Increase the dose.
You need to stop. Look, I think you have to stop and put
one at a time, please. I'm listening. Blay. I'm listening.
Look, I'm thinking that you need to stop the warfarin and probably shift to different medication like rivaroxaban types or any other medication that will not cause a serious kind of bleeding.
You have initiated 5 milligram. You check the INR. You are expecting it to be in between 2 to 3. You check this is less than 2. What should be done for the patient?
Doc, you can give vitamin K.
You can do it. Come again.
You give vitamin K to the patient, then you stop the medication.
Oh God, have mercy. What will you do?
Sir, please reduce the dose
Increase
of the
the dose.
So increase the dose. When you check and it's below 2, what does it mean?
Like I said, there's possibility of coagulation. So you need
probability of coagulation. So what will you do?
You need to increase.
You increase the dose.
You increase the dose. So why do you say that we should take the patient from
warfarin?
From warfarin? Why?
Sorry.
So we check it below 2. So it means the risk is high in terms of coagulation. You need to increase the dose. You can do 7.5. That is why there should be a daily check of these iron, such that you can get the right dose for the patient.
Dr. Attakorah.
Hi.
Dr. Attakorah.
Hi. Hello.
Please, with the warfarin, when it's initiated, after what duration are we expecting to see the change in the INR?
When you initiate it.
Because if the time is short, it might still not reflect the true effects of the drug. If maybe it hasn't started working as it's supposed to work, and we check.
When you initiate it, there's a danger in initiating warfarin. When you initiate it, warfarin is a prothrombotic. And two, warfarin, before warfarin starts working, so anticoagulant action of warfarin will take about 3 to 4 days. Do you get it? So after 4 days, I'm expecting warfarin to take off, because by then the already formed activated clotting factors would have been cleared from the system. Warfarin will not have effect on already formed activated clotting factors, and some can take about 72 hours, 50 hours, 36, depending upon the type of that clotting factor. And therefore, when warfarin takes up after 4 days, you can do a regular check.
So, Dr. Attakorah, your question, when was it checked? I think that also depends on your intervention, because if it's checked earlier than the 3 to 4 days, definitely we're not going to see the effect. So maybe you monitor and wait until you reach maybe the 4th day, then check. And if it's still less than the 2, maybe you increase the dose. That was what I was thinking.
So I'm saying all things being equal. You check. You gave warfarin to a patient. You check. I just want you to learn something from here. You checked it. It's less than 2. What will you do?
You increase the dose.
You increase. This is what I want you to learn. If I'm expecting INR between 2 to 3 and it's below 2, what am I going to do? So this is not by way saying what you are bringing in, you are from a different way, which is good in terms of learning. But I'm saying that if you have, do you get me? You want to tell us that even a time of checking is INR is important. But I'm saying that if the patient is on, you have checked, it's less than 2. How will you go about it? What you are also coming from is a way for us to also think in our learning. It helps. But what will you do? A patient is on 7.5. And you check the INR and it was above 3. What will you do? And what does it mean?
Dr. Attakorah,
Hello?
please, with the first question too, can you also first maybe investigate into what the kind of food the patient takes? Maybe the patient is taking food that contains the content of the vitamin K in the food is the patient has been taking is too high. So maybe it's not the dose, maybe it's the food that the patient is taking. So maybe you advise the patient and reduce the dose and the kind of try and give dietary advice to the patient before maybe you increase the dose. Can that want to be done?
That is why I said I used the word all things being equal. I said this. In terms, who answered that question in terms of the food? What will be this? So it means that we have dealt with all this. You get it? We say that if a patient is taking green leafy vegetables also, we say that we'll be giving the same amount to the person every day, the same amount. So, assuming we are giving the same amount to the patient, we started by talking about that. And we check the INR and it's above 3. What would you do? If there's lapses like the patient is eating anything, then you can be thinking about. But if you are strictly following orders, take this amount every day. The patient is taking the same amount every day. And the INR is above 3. What will you do? Are you following?
Yes.
Are you okay with what I'm saying?
Yes.
You understand?
Yes. Oh.
So you are telling the patient to take this amount every time, this amount. The patient is taking it. Then a lab was done. INR 4.5. What will you do?
Doc, you need to reduce if it's 4.5, it means that it's above the upper range of the normal. So you need to reduce the quantity of the warfarin that you are giving.
So a dose, you need to reduce the dose. This is what I want you to know how to maneuver your way. But when you are giving warfarin, then that is why, do you know what? Normally you'll be giving warfarin, then if it's the DVT, then you think about giving it with Clexane because of these things. Because of the onset of action for warfarin. Because of the effect of warfarin on the clotting factor. Okay, so this is that.
Hello, sir.
Hello.
Yeah. So, please, apart from decreasing the dose of the warfarin if the INR is above 3, can you also educate or counsel the patient about the intake of his or her green leafy vegetables?
I see there's a problem here. So the point is that if all these things are done for the patient, hey, If we have done your counseling, you have counseled your patient. If all these things are done, then lab is done for the INR checks, it's done for the patient and it's hard. What will you do? This is what I want. But you need to be talking to the patient. It's not only about the food. It could be about the side effect. It could be about the bleeds and so. So you need to talk to the patient about the medication. Any other medication that the patient is taking, if that medication also has that tendency to cause bleed, you need to talk about it. So it's not only the green leaf. It's not only that. I'm saying if everything is done for the patient. Your other colleague was talking about times that we'll be checking the iron. I'm saying that if you are checking it after, that's why I say all things being equal, if everything is okay, it's in line. You done your checks and it's high and below, what would you do to the dose? But in giving warfarin, you need to be doing this iron now and adjusting the dose. Think about the food that the patient is eating. Are you okay?
Yes, please. Thank you.
So let's meet tomorrow and start IBD. IBD. Okay. So good night. Fine. Go and sleep. You are tired. Some of you are so. You are shivering within. Some are not even eating because of this. Some are sleeping. Some are sleeping in classrooms. You have been able to finish your seat here, where you were learning about oncology, learning about emergency. So if you are getting A and B in all these things and you can't do this, then I would look into your exams well. It will be well, right? Go and learn. So I'll be meeting you tomorrow. Bye.
Dr. Attakorah, the time is too slow.